Bismillahirrahmanirrahim. Today we are going to learn about the diabetes insipidus. Diabetes mean to pass through and insipidus mean tasteless, having no taste. So the production of large amount of dilute urine by the kidney due to decreased secretion of antidiuretic hormone or due to decreased effect of antidiuretic hormone. Diabetes insipidus is characterized by the various symptoms including the polyuria, polydipsia, dehydration, headache, weakness and lethargy. To know about the diabetes insipidus thoroughly, we should go into the background. In this slide we can see that this is the pituitary gland. This is the posterior pituitary gland, that is also called neurohypophysis. This is called neurohypophysis because this is the part of the neuronal system. The anterior pituitary gland is called adenohypophysis because that is the part of endocrine system. Adeno for endocrine. And hypophysis means pituitary gland. So this is the posterior pituitary gland. This is called neurohypophysis, and this is the pituitary stalk. That is called infundibulum. Through this stalk, the neurohypophysis is attached with the hypothalamus. This is the hypothalamus. Above the hypothalamus, there is a membrane that is called lamina terminalis. This is the membrane which is called lamina terminalis. Lamina terminalis is provided by the large amount of blood vessels that is necessary for the function of lamina terminalis. I am going to show you in the next slide. In this slide, we can see that this is optic chiasma. Optical chiasma or optic chiasma is the overlapping point of the optical nerve. The optic nerve that goes from the eyeball, from the retina to the visual cortex, and the two rays of the optical nerves overlap over here below this area of the brain is called hypothalamus. So in this area, the optic chiasma, the overlapping of the optical nerve occur. Above the optic chiasma in the hypothalamus, there is a nucleus that is called supraoptic nucleus. Supra mean above and optic mean optical chiasma, and nucleus is the nucleus accumulation of cell bodies. Cell bodies are various types of cells. Above the supraoptic nucleus, there is another nucleus, small in size, that is called median preoptic nucleus. This median preoptic nucleus is actually above the free optic nucleus. Over here, there is a free optic nucleus that is not given in the diagram, but above the free optic nucleus, there is the median free optic nucleus. So median free optic nucleus is above the supraoptic nucleus over here. So this is the optic chiasma, this is the supraoptic nucleus, and this is the median free optic nucleus. The median free optic nucleus is adjacent with the lamina terminalis. This is the lamina terminalis, and lamina terminalis is in contact with the blood-brain barrier, or in contact with the large amount of capillaries. This membrane, the lamina terminalis, contain large amount of organs, small organs, and these organs are called subfornical organ and organum vasculosum. Organum vasculosum and subfornical organ. These small organs are responsible for the detection of osmolarity, for the detection of sodium concentration, for the detection of blood volume, for the detection of blood pressure also. I'm going to show you in the next diagram. And in this slide we can see over here there is another nucleus that is called paraventricular nucleus. Above the paraventricular nucleus there is the third ventricle of the brain, that is why, and this is parallel with the third ventricle, that is why this is called paraventricular nucleus. Now going towards the complexity. This supraoptic nucleus and this paraventricular nucleus, these two nuclei are actually responsible for the function of posterior pituitary gland. If I talk about the antidiuretic hormone, the more than 90% of antidiuretic hormone is secreted by the supraoptic nucleus, is produced by the supraoptic nucleus, and that is transferred through this tract. This tract is called hypophyseal tract, and that is stored in the herring bodies. These are actually the axonal terminals. In this nucleus, in the supraoptic nucleus, the cell bodies of neurons are there, and the cell bodies of neurons give rise to the axon. These are axonal fiber, and these axonal fiber or hair give rise to the axonal ending, nerve ending, and these nerve ending give rise to small bodies, and these bodies are called herring bodies. Herring bodies I have written over here. So more than 90% of antidiuretic hormone is synthesized inside the supraoptic nucleus, and less than 10% of the antidiuretic hormone is synthesized inside the paraventricular nucleus. That is then transferred to these nerve endings. So now coming toward the stimulation and secretion, there are various factors. For example, I am talking about this area. This area is called lamina terminalis, and lamina terminalis have the two types of organs, small organ, subphonical organ and organum vasculosum. These subphonical organ and organum vasculosum are in contact with the blood-brain barrier, in contact with the capillaries and various blood vessels. So if there is, what I am going to write the factors, if there is increase osmolarity, if there is decreased blood pressure, if there is decreased blood volume, these three factors, or there is increased stress, these four factors, basic factors, these four basic factors are responsible for the secretion of, for the stimulation of lamina terminalis, for the stimulation of these two organs, for the stimulation of organum vasculosum, and for the stimulation of subphonical organs. So after the stimulation of organum vasculosum and subphonical organ by these factors, increase in osmolarity mean increased electrolyte concentration and decreased the water amount, decreased quantity of water inside the blood, and increased viscosity, increased osmolarity, increased electrolyte level. So when the blood become more viscous, when the viscosity of the blood increases, when its osmolarity of the blood increases, when the ionic concentration of the blood increases, or when the water quantity of the blood decreases, this gives rise to increased osmolarity. So by these factors, by the arousal of these factors, these four factors, what happens? These two organum vasculosum and subphonical organ are stimulated. These have osmoreceptors which stimulate these organs. So after the stimulation of these organs, this gives signal to the median free optic nucleus, and the median free optic nucleus gives signal to the supraoptic nucleus. So this supraoptic nucleus carry out two functions. By the stimulation of the median free optic nucleus, this supraoptic nucleus carry out two functions. I am going to tell you in detail. It starts synthesis of antidiuretic hormone, and it also gives signal to the herring bodies or hair for the secretion of antidiuretic hormone. Two processes. It increases the synthesis of antidiuretic hormone. This median free optic nucleus also stimulate this nucleus, and by the stimulation of these two nuclei, the synthesis of antidiuretic hormone is stimulated. It also stimulates the secretion of the transfer of antidiuretic hormone to the herring body, and it also gave rise to the secretion of antidiuretic hormone into the capillaries. So these are the capillaries. These are called hypophyseal veins. These hypophyseal veins are there for the acquisition, for the reception of these hormone. So the hormone that is secreted by the herring bodies over here, that is the antidiuretic hormone, and antidiuretic hormone is transferred into the hypophyseal vein. After transferring into the hypophyseal vein, this hypophyseal vein distribute this antidiuretic hormone throughout the body through the venous and circulatory system, and eventually this antidiuretic hormone reaches over here into the kidney. I'm going to make it a little broader. Over here we can see that the antidiuretic hormone is responsible. The antidiuretic hormone is secreted over here on the distal convoluted tubule. This is the distal convoluted tubule of the nephron. This is the nephron. This is the whole nephron. This is the efferent arteriole. This is glomerulus. This is the efferent arteriole. This is the Bowman capsule. This is the proximal convoluted tubule, descending convoluted tubule, the descending tubule. This is loop of Henle. This is the distal convoluted tubule, and this is the collecting duct. So in the collecting duct is surrounded by the special type of cells which are called the principal cells. These are the principal cells. So the antidiuretic hormone activate the principal cells. The principal cell contain the receptor which are called V2 receptor or antidiuretic hormone receptor, ADH receptor or vasopressin receptor, V2 receptors. And these V2 receptors upon activation gave rise to the absorption of water. So the antidiuretic hormone over here act on the collecting duct, and the collecting duct is responsible for the reabsorption of water from the collecting duct into the venous system, into the circulatory system. Now focus on this area. This area is represented over here as such. This is the vein. These are the peritubular capillaries. These are the veins or peritubular capillaries. In this diagram we can see over here, we should focus on these two diagrams, on this area especially. This area represent, this is the peritubular capillary, which is responsible for the secretion of ADH. So these peritubular capillaries are adjacent with the principal cell of the collecting duct. So in this diagram, this is the peritubular capillary, this is the principal cell, and this is the tubule of the collecting duct. Now just focus on this diagram. So the ADH, which is transferred through the circulatory system and to the kidney, that reaches over here to the collecting duct, and the peritubular capillaries. From the peritubular capillary, this ADH is secreted over here, and this V2 receptor, this is the V2 receptor, G protein coupled receptor, is activated. Upon the activation of G protein coupled receptor, the adenylyl cyclase enzyme is activated. This adenylyl cyclase enzyme gave rise to the formation of cyclic AMP, adenosine monophosphate, and this cyclic adenosine monophosphate stimulate the protein kinase A. This protein kinase A receptor is the enzyme that is responsible for the translocation of the aquaporine. The aquaporine are the tubule or the channels which are over here in the vesicle. So by the activation of protein kinase A, these aquaporine channel, it actually gave rise to the activation of cascade of a reaction. At the end of that reaction, the translocation of the aquaporine pore channel. The aquaporine pore channel are transferred or translocated from this vesicle into this area. This is the apical membrane of the principal cell, and this is the basolateral. This is the basolateral membrane. This is the basolateral membrane, and this is the apical membrane. So it translocate the aquaporine 4 channel, the aquaporine channel, aquaporine 2 channel, not 4 channel, aquaporine 2 channel into this membrane. This is the apical membrane. Okay. By the translocation of these channel, the water is going to absorb into these cells, into the principal cell. By the absorption, it carry out the absorption of water from the collecting duct. So the absorption of water over here into principal cell will lead to the absorption of this water into the interstitial spaces. These are the interstitial spaces through aquaporine 3 and aquaporine 4 channel. So the aquaporine 3 and aquaporine 4 channel are on the basolateral side of this principal cell. So when the water is absorbed by the aquaporine 2 channel, this water is reabsorbed by the aquaporine 3 and aquaporine 4 channel into the interstitial spaces. From the interstitial spaces, this water goes into the venous system or the circulatory system of the body. So what happened? Going to the next diagram, the effect of the ADH was there, the reabsorption of water. Over here you can see this is the absorption of water. So by the secretion of ADH from the posterior pituitary gland, the water is reabsorbed from the distal convoluted tubule, from the collecting duct of the nephron. So by the reabsorption of water from the collecting duct of the nephron, the concentrated urine is formed normally. But if there is decreased secretion of no secretion of the antidiuretic hormone, if there is no secretion of antidiuretic hormone from here or from here, what will happen? There will be no secretion of ADH over here, and there will be no absorption of water, and there will be increased excretion of water. There will be increased loss of water by the nephron through the collecting duct. There will be increased loss of water. So increased loss of water from the body will lead to the dehydration, to the polyuria, polydipsia, dehydration and other symptoms. That is what we call diabetes insipidus. So these are the principal cell and this is the collecting duct. In this diagram you can see that if the diabetes insipidus is due to the defect in the pituitary gland, in the posterior pituitary gland, that will be called the central diabetes insipidus. Or if there is a decreased effect of the antidiuretic hormone due to defect in the kidney, that is called nephrogenic diabetes insipidus. Nephrogenic, nephro mean kidney and genic mean to make. Okay? So the nephrogenic diabetes insipidus is actually due to some abnormality in the kidney, due to kidney abnormality. The nephrogenic diabetes insipidus is never due to decreased amount of antidiuretic hormone. The antidiuretic hormone in the nephrogenic diabetes insipidus is normal or more than normal. But there is defect, but there is abnormality in the kidney. That is why the receptors, the V2 receptor inside the kidney, inside the collecting duct of the kidney of the nephron, there is no sensitivity of these receptors. So the water absorption over here is nullified. There is no water absorption due to defect in the kidney. They are due to blockade of the vasopressin receptor, V2 receptor. Both the central diabetes insipidus, that is due to defect in the pituitary gland, or the nephrogenic diabetes insipidus, that is due to defect in the kidney. That is the symptoms of all. Both of these have the same symptoms almost. That is the polyuria, increased amount of urination; polydipsia, increased thirst; dehydration, loss of water; dehydration, decreased amount of water in the interstitial spaces and intracellular; headache is conspicuous in both the central diabetes insipidus and nephrogenic, because the water amount is very less inside the blood, and the blood is very much concentrated. So there will be, due to increased concentration of the blood, there will be headache. So weakness will also be there, because it will also lead to the excretion of various other matters, and the weakness is also there due to decreased blood pressure, due to decreased blood volume, due to decreased blood supply to various parts. Actually, the weakness is there due to increased secretion of water. Water is responsible for the dissipation of various energy matter, for the dissipation, for the distribution of various entities that are responsible for the energy making, for responsible for ATPs, and the water amount is already there. The water amount is already low in the diabetes insipidus. So what will happen? There will be weakness, there will be lethargy, there will be drowsiness, there will be decreased energy inside the body. But the clinical features of the central, and these are the clinical features, are the symptoms uh, which are defected in both the central and the nephrogenic. But the central diabetes insipidus will also have severe headache. This will also have some confusion. This will also have some brain abnormalities. And the nephrogenic diabetes insipidus will have the abnormality in the kidney abnormality, pain in the kidney, and various other associated symptoms that is prevalent with the kidney diseases. Now, what is the etiology of these two? The etiology are the causes of the diabetes insipidus, the central diabetes insipidus, and the Sheehan syndrome. Sheehan syndrome is actually the decreased blood supply to the brain due to increased postpartum hemorrhage, blood loss. Sheehan syndrome is the various symptoms, collection of various symptoms which arise from the hemorrhage of the postpartum, after when a mother gave birth to the baby, and in most cases there is placenta previa. So when gave birth to the baby, and there is increased loss of blood from the uterus, increased loss of blood from the body after giving birth to the baby, postpartum hemorrhage, that is called postpartum loss of blood. So that gave rise to decreased blood volume and decreased blood supply to this gland, to this pituitary gland. So decreased blood supply to the pituitary gland due to postpartum hemorrhage, that is Sheehan syndrome, and it will lead to the necrosis of the nucleus that is responsible for the formation of antidiuretic hormone. So decreased antidiuretic hormone is due to Sheehan syndrome. Secondly, the macroadenoma. One is called the microadenoma and the other is called macroadenoma. So the microadenoma is having the size of less than 10 millimeter, and more than 10 millimeter is called the macroadenoma. So the macroadenoma is the adenoma or the tumor of the pituitary gland, the anterior pituitary gland that is more than 10 millimeter. If the size of the pituitary gland, of the tumor of the pituitary gland, is more than 10 millimeter, it will compress the pituitary gland. It will compress this pituitary gland. Actually, this adenoma is the adenoma of the anterior pituitary gland. So the anterior pituitary gland, when the gave rise to more than 10 millimeter adenoma, it will compress the posterior pituitary gland, and due to compression of posterior pituitary gland, it will lead to the secretion of very less hormone, very less antidiuretic hormone. The third one is pituitary apoplexy. Pituitary apoplexy means pituitary apoplexy, you can say it a type of infarction or stroke or necrosis or hemorrhage of the pituitary gland. So if there is tumor and tumor gets ruptured, so due to rupture of the tumor, when the tumor size is very large and it give rise to the rupture of the pituitary gland, so that tumor the rupture of that tumor are due to the rupture of capillaries or due to the rupture of other blood vessels inside the sella turcica. Actually, this pituitary gland is present inside a fossa, inside a cavity of the sphenoid bone that is called the sella turcica. So when the blood vessel rupture over here, or when the adenoma rupture over here, this leads to the infarction of this pituitary gland, infarction of this area. So the infarction of this gland is called pituitary apoplexy. This is actually pituitary stroke, or this is actually pituitary hemorrhage, or you can say it the pituitary infarction due to the rupture of the adenoma. Adenoma is usually happen inside the anterior pituitary gland, as I have told you. So due to rupture of the adenoma, or due to rupture of the blood vessels, or due to hemorrhage, what will happen? This will decrease blood supply inside this pituitary gland, and this will lead to the infarction of the pituitary gland, and this is what we call the pituitary apoplexy. This will lead to decreased secretion of or no secretion of the antidiuretic hormone. On fourth number, you can see infection. The infection rarely gave rise to the diabetes insipidus, but in some cases, when the meningitis is very much vigorous, there is very much vigorous meningitis inside the brain, so the meninges, so the increased meningeal infection can also lead to the diabetes insipidus. Now the NDI, the nephrogenic diabetes insipidus, can be due to drugs. Which type of drugs? When someone is using certain types of drugs, that is, for example, you can say demeclocycline, or lithium or demeclocycline. These are two types of drugs which can inhibit these channels, which can inhibit these receptors. These two drugs inhibit the V2 receptor. So the inhibition of V2 receptor inside the kidney due to these two drugs gave rise to the production of large amount of dilute urine, and that is the nephrogenic diabetes insipidus. So the chronic kidney disease also gave rise to diabetes insipidus, because the collecting duct are not normal in the chronic kidney diseases, and there is no translocation, and there is no propagation, or there is no sensitivity of the ADH hormone. So genetic one is the genetic cause. That is also somewhat that is also not rare, but genetic is also responsible. Some genes are responsible for the induction of this disease, nephrogenic diabetes insipidus. Pyelonephritis, the infection of kidney. Infection of kidney can also give rise to diabetes insipidus. And electrolyte balance, most importantly, the electrolyte balance due to any abnormality inside the kidney, or due to any abnormality of any other hormone, or due to malnutrition or any other factor, but there will be decreased, there will be electrolyte imbalance of the electrolyte can also give rise to the production of large amount of dilute urine. That is nephrogenic diabetes insipidus. Now the diagnosis of diabetes insipidus is through CT scan, the MRI, the XRD, the X-ray, the serum electrolyte level. So this is the central diabetes insipidus. Central diabetes insipidus can be diagnosed with the help of CT scan, MRI, and XRD, X-ray. We will take the images, we will screen the images of the pituitary gland through MRI, XRD, or the computed tomography. And then second number, that is the serum electrolyte. The serum electrolyte level also used for the detection of diabetes insipidus, because the sodium level will increases. The sodium level, which is normally more than 135 and less than 145, in between 135 and 145. If the sodium level is more than 145, that is the diabetes insipidus. But in most cases, the sodium level, I'm going to write it over here. The sodium level 145, less than 145 is normal, but if this is more than 145 to 170, this is normally the CDI, the central diabetes insipidus. But if the sodium level is above 170, this will be the nephrogenic diabetes insipidus, NDI. The urine normal osmolarity is more than 300 or more than 500 osmolarity. This is the normal osmolarity of the urine. But if the osmolarity is below 300, it means the osmolarity is very low, less than 300, because the urine is very dilute, not concentrated. The dilute urine or the non-concentrated urine formation will decrease the osmolarity, decrease the concentration of electrolyte. So there will be decreased electrolyte inside urine, and there will be decreased concentration of the urine. There will be dilute urine formation, so the osmolarity will be less than 300. Normally, if this is more than 500 or more than 300, then normally it ranges from 300 to 500. In between the 300 and 500, this is normal, but below 300, this is diabetes insipidus. The urine specific gravity is normally 1.005 to 1.035. This is the normal range of urine specific gravity. So in the diabetes insipidus, in the case of diabetes insipidus, this is less than 1.005. So the urine specific gravity, the copeptine, this is very important. Copeptine is a hormone. Copeptine is a protein that is secreted along with the antidiuretic hormone by the posterior pituitary gland. This copeptine, if your blood contains the copeptine, it means that the posterior pituitary gland is working. It means the posterior pituitary gland is normal. The posterior pituitary gland is secreting the antidiuretic hormone. So this copeptine, the presence of copeptine inside the blood indicate that your posterior pituitary gland is normal. This copeptine is used generally for the differentiation, normally for the differentiation of the primary, for the differentiation of central and nephrogenic diabetes insipidus. So the copeptine is a protein that is secreted along with the antidiuretic hormone. Just like the C-peptide, is secreted with the insulin by the pancreas. So the C-peptide differentiate between the diabetes type 1 and diabetes type 2, diabetes mellitus type 1 and diabetes mellitus type 2. In this case, this diabetes insipidus, central versus nephrogenic, is differentiated by the copeptine. If the copeptine is there inside the blood, it means that this is not the central diabetes insipidus. The diagnosis of the nephrogenic by the renal function test, the urine routine examination, the ultrasound of the kidney, urinary bladder, and the ureter ultrasound, and the clinical feature also differentiate because the clinical feature of the central and the nephrogenic is different from each other. So the most important is the differentiation. How to differentiate between these two, the CDI versus NDI. The CDI is central diabetes insipidus. Desmopressin you will give desmopressin injection to the patient. After giving the desmopressin injection to the patient, if the the urine output become low. There is decreased urine output. It means that this is the central diabetes insipidus, because if there is no secretion of the antidiuretic hormone, then the desmopressin will work over there. But if there is secretion of antidiuretic hormone but your kidney is not functioning, this is, for example, this is nephrogenic. In the case of nephrogenic diabetes insipidus, the desmopressin will not work. Desmopressin will not work in the nephrogenic, and desmopressin will work in the central diabetes insipidus. So this is used for the differentiation of the central versus the nephrogenic diabetes insipidus. So the second one is the copeptine. Copeptine is secreted with the antidiuretic hormone normally. So the presence of copeptine inside the blood indicate that this is not central diabetes insipidus. This is the nephrogenic. Similarly, the sodium concentration. If the sodium concentration is above 170 millimole per deciliter, then it will show that this is the nephrogenic diabetes insipidus. But if the sodium concentration is normal, or if the sodium concentration is in between 145 and 170, mean low sodium concentration from the nephrogenic one, below 170, so it will show the central diabetes insipidus, because I'm going to show you the logic. In the central diabetes insipidus, the antidiuretic hormone is not secreted. The antidiuretic hormone is not secreted, but the sodium concentration is maintained by the kidney, because the kidney is normal in the central diabetes insipidus. So the sodium concentration is somewhat normalized by the kidney in the central diabetes insipidus. But in the nephrogenic diabetes insipidus, the antidiuretic hormone is secreting over here, but that is not functioning over here, and the antidiuretic hormone is not functioning over here, and the kidney is not functioning over here in the absorption of sodium, in the maintenance of sodium and other concentration, other electrolyte concentration. So the kidney is not going to balance the sodium. So the sodium will rise and go above 170. Now coming towards the treatment. The treatment of the primary is the desmopressin, because the desmopressin is the analog of the antidiuretic hormone, the vasopressin. Secondly, the increased water concentration, water intake. The patient will increase water intake. Similarly, the patient will monitor the electrolyte balance. The electrolyte, if there is decreased electrolyte, some electrolyte is decreased, so you will replace that electrolyte. The electrolyte replacement will be there after the monitoring of the electrolyte. If there is decreased or increased electrolyte, you will balance that electrolyte. That monitoring is essential. But over here there is in most cases the sodium balance is normal. The water amount is low inside the body. There is dehydration, so you will increase the water, but you will not increase, or you will not decrease the sodium in most cases. Similarly, in the nephrogenic, the disease, the underlying disease should be treated, because this is due to, in most cases, this is due to the underlying disease. Similarly, you will avoid the medicine which is going to increase the urine output. The medicine, that is the demeclocycline, that is the lithium and demeclocycline are responsible for the nephrogenic diabetes insipidus. So you will avoid those medicine to treat the nephrogenic diabetes insipidus. The diuretic, the thiazide diuretic are the mainstay drugs, the key drug for the treatment of nephrogenic diabetes insipidus. Because the thiazide diuretic, normally what happens in the nephrogenic diabetes insipidus, normally the kidney will produce large amount of water. The kidney will drain large amount of water into the urinary bladder. But kidney will not drain large amount of sodium to the urinary bladder. The kidney will not pass the sodium. The kidney will only pass the water. So by giving the thiazide diuretic, what will happen? The thiazide diuretic will increase the excretion of sodium, and it will normalize the excretion of water. So thiazide is the mainstay drug for the treatment of nephrogenic diabetes insipidus. So you will also increase the water content, you will water intake, and decrease the sodium concentration, the sodium intake. So this was all about the diabetes insipidus. The main drug for the treatment of central diabetes insipidus is the desmopressin. And the main drug for the treatment of nephrogenic diabetes insipidus is the thiazide diuretic, the hydrochlorothiazide, usually 12.5 milligram.